Hello, my name is Dr. Andrew Kolodny. I am the medical director for the Opioid Policy Research Collaborative at Brandeis University. I'm going to be talking with you today about the opioid crisis. I'm going to start by explaining where we are in the crisis. I'll give you some of the latest data on overdose deaths. I'm going to help you understand why we should still care about prescription opioids at a time when most opioid overdose deaths involve illicitly synthesized fentanyl. I'm going to then discuss how the opioid crisis happened with a particular focus on the role of hospitals. I'll cover the appropriate role for opioid prescribing when it comes to acute pain management. And then lastly, I'll cover some big picture strategies for bringing the opioid crisis under control. I'm going to start by saying something that should be obvious, but unfortunately is not obvious. It's not obvious to many clinicians who prescribe opioids. It's certainly not obvious to many patients who take opioids. When we talk about prescription opioids, we are literally talking about drugs that come from opium. Oxycodone and hydrocodone are literally made from opium. They are what we would call semi-synthetic opioids because you start essentially with opium, something natural, to make them. Heroin is also a semi-synthetic opioid. When you create that semi-synthetic opioid, you're tweaking the natural opioid molecule so that it gets into the brain faster and has a more rewarding effect. Something that's been studied is the likability of different opioids. And in fact, heroin has been compared in its likable effects to oxycodone and other opioids. And in that study, the oxycodone actually beat out the heroin as having more likability among experienced drug users. So my point here is that when we talk about some of these commonly prescribed opioids, we are essentially talking about heroin pills. Now, to say that doesn't mean that doctors should never prescribe opioids. These are important medicines, particularly for treating pain at the end of life. But unfortunately, to this day, the bulk of opioid prescribing in the US is for conditions and in a manner that's more likely to harm a patient than help a patient. And that's why we're here today. If you've been following the news on drug overdose deaths in the United States, if you've been following the news closely, you may be aware that for the past 2 years, deaths from drug overdose have come down in the United States. This has been big news because for more than 25 years, every year we were setting a record in the United States for death from drug overdose. And then the next year we would break that record. And we kept seeing year after year the opioid crisis in terms of the deaths getting worse. Around 2014, the problem wasn't simply getting worse. We began to see a soaring increase in overdose deaths as illicitly synthesized fentanyl, which is much more potent than heroin, became the dominant black market opioid. But this big news that since around the fall of 2023, opioid overdose deaths have been coming down. That's something that's been really striking and obviously something that can leave us hopeful that there's some light at the end of the tunnel. The trend toward decreasing overdose deaths since 2023 is something we're seeing in almost every state in the country. To really understand the trends in opioid overdoses, though, it's important to consider the epidemiology of opioid use disorder. On this slide, you see that we roughly have three groups of opioid addicted Americans. The first group of opioid addicted Americans are individuals who are generally in their 30s and 40s today. These are individuals who developed opioid addiction, taking prescription opioids, and then wound up on the black market. These are people who got addicted mostly in the late 90s, early 2000s, these when they were young adults. And they became addicted to prescription opioids that they were taking either for a medical reason and then got hooked, or they might have been using them recreationally and got addicted. And once addicted, this was a group that wound up on the black market and wound up ultimately switching to heroin after becoming opioid addicted. Because even in the early 2000s, doctors were generally uncomfortable prescribing large amounts of opioids on a monthly basis to healthy looking 25-year-olds. So this group, once they got addicted to the pills, even if they became addicted through medical treatment, they often wound up on the street. The pills have always been very expensive on the streets. And if they were in a region of the country where heroin was available, they switched to heroin because it produced the same effects as prescription opioids, as we mentioned, but was much less expensive. The second group of opioid addicted Americans are individuals who are in their 50s, 60s, 70s, and 80s. These are people who became addicted to prescription opioids through medical treatment. Many of them were prescribed opioids after a surgical procedure, maybe after an accident, or prescribed opioids aggressively and never came off. And these are people who generally receive a monthly prescription of opioids for a diagnosis of chronic pain. And so that's the second group of opioid addicted Americans, middle-aged and older individuals prescribed opioids for chronic pain. The third group of opioid addicted Americans are in their 60s and up, and this is a group that's disproportionately Black and Latino. These are individuals who are also disproportionately from urban areas that were hit very hard with heroin in the 1970s, where there's been sort of an endemic heroin problem in these communities since the 1970s. And so this is also a group that has been relying on black market opioids. These are folks for whom their opioid addiction began with heroin. They didn't switch to heroin. Now, if you look at what's been happening since fentanyl emerged in around 2014, what we started to see is that in that first group I mentioned and the third group I mentioned, we began to see a soaring increase in overdose deaths because these were groups that were relying on the black market heroin as the heroin supply increasingly became mixed in with fentanyl and then essentially replaced by fentanyl. We started to see the deaths in those two groups go up rapidly. In that middle group, beginning around 2014, we've actually seen fewer deaths. This is a group that's been doing a bit better as the medical community started to prescribe opioids more cautiously. Something many people don't realize is that before fentanyl emerged, if you were to look at these three different groups that I told you about, the younger group that wound up switching to a black market supply after getting addicted to prescription opioids, the middle-aged and older group that never really needed to switch to the black market has generally been able to get pills more easily from clinicians. And the third group that's disproportionately non-white, long-time heroin users, also disproportionately male. When you compared where we were seeing the most deaths Before fentanyl emerged, the group that was really hit the hardest, where we saw the largest rate of overdose deaths, was that middle-aged group. That group's doing a bit better now that prescribing has trended more cautious in terms of overdose deaths, but it's a group where the best data tells us we have almost 5 million Americans who are hooked on opioids that are prescribed to them for pain. And when you look at that 5 million Americans with addiction to prescription opioids, something we've learned recently through a study that the federal government did, we found out that more than half of these individuals actually take their opioids as prescribed. They don't misuse them. We consider them to have opioid use disorder, even though they're taking their opioids as prescribed, because the opioids are having a negative impact on their life, and yet they remain stuck on opioids. Now that we've covered the epidemiology of opioid use disorder, let's talk a bit about the opioid crisis. And let's talk about how we should understand the problem, how we should frame it. Very often, when the opioid crisis is referred to, it's with a focus on the overdose deaths. But I'd like you to think really a bit more broadly about what the problem, what is really driving the problem, and how we should understand it. And I think the most precise way to really describe the opioid crisis is as an epidemic of opioid addiction or opioid use disorder. When you describe the problem as an epidemic of opioid use disorder, what you're saying is that the reason that the United States is experiencing record high levels of opioid overdose deaths, and the reason we're experiencing an array of health and social problems that we refer to as the opioid crisis is because the number of Americans with opioid use disorder increased rapidly. If you could go back in time, for example, to the early 90s, opioid use disorder in the United States was uncommon. Where you saw opioid use disorder was generally in low-income inner city communities that had a long time heroin problem. Outside of those communities, in suburban communities and rural communities, death from opioid overdose and opioid use disorder were uncommon. Today, death from opioid overdose is the leading cause of accidental death, and about 5% of adults in the United States have opioid use disorder. And so the right way to really understand the crisis is as an epidemic of opioid use disorder, meaning a sharp increase in the number of Americans addicted to opioids over a short period of time. And when you have opioid use disorder as a common condition, you don't only see high rates of overdose deaths, you also see high rates of infants born opioid dependent. You see high rates of injection-related infectious diseases, an impact on the workforce, children winding up in foster care because of their parents' opioid use disorder. All of these health and social problems have really been driven by the increase in the number of people in the United States who now suffer from opioid use disorder. So now that we've explained that, I want to show you the epidemic happening over time with this series of maps. So let's start with 1999. What you're looking at here is a map of the United States 3 years into the epidemic. And what you can see is that 3 years in, there were a few states lighting up as having a problem. So the states that are showing up as red or maroon on this map are the states with the highest rate of people showing up at state licensed drug and alcohol treatment programs saying that the primary drug that they're addicted to is a prescription opioid. And so you see a few states were already lighting up as having a problem 3 years into the epidemic. And I'll explain in a moment why I believe the epidemic began in the year 1996. So this is 1999. I'm going to show you what happens as we go up in 2-year increments. This is 2001, 2003, 2005, 2007, and 2009. What you can see is that by 2009, every state in the country had experienced a sharp increase in the number of people seeking treatment for addiction to prescription opioids and the number of people suffering from opioid use disorder. And again, when you have a sharp increase in the number of people suffering from a disease over a short period of time, that is the definition of an epidemic. So let's talk now about what caused the maps to turn red. What really drove the opioid crisis? I think the best answer to that question came from the CDC. And what you see on this graph with these three lines going up, this CDC graph was for many years one of the chief speaking points from the CDC on the opioid crisis. The point that the CDC was making with this graph is that as the green line went up, the green line representing sales for prescription opioids, as the green line went up, the red line and the blue line went up along with the green line. And the red line represents deaths involving prescription opioids, and the blue line represents addiction involving prescription opioids. The CDC's point here was that over prescribing of opioids was fueling an epidemic of opioid addiction and death. And the CDC's message to the medical community was that if we wanted to bring this problem under control, the prescribing needed to start to come down. Now, I can tell you that uh, drug companies that make prescription opioids have not agreed with the CDC. And initially, as those lines were going up, the opioid manufacturers, the pharmaceutical companies like Purdue Pharma that make opioids, that made OxyContin, they were paying scientists to put out papers saying that this isn't happening. There were papers published in medical journals saying that the prescribing is going up, but that there's no evidence of any adverse public health problem. Those papers were coming out until around 2004. Then at that point, the data just became overwhelming that, in fact, there were public health problems associated with the increase in the prescribing. And then you started to see a different message from the opioid industry, a message that the green line should still go up, but that we could make the red and the blue line go down if we make the pills harder to crush, so-called abuse deterrent formulations. If we teach doctors to monitor their patients more carefully, then we can have it our cake and eat it too, was the messaging. And of course that would never work. But unfortunately, that messaging did for many years effectively impede efforts to bring that green line down, to really bring the epidemic under control. I want to show you also what could have been a fourth line on that CDC graph. What you see here is the rise in neonatal opioid withdrawal syndrome. These were infants born opioid dependent who needed to really be treated for opioid withdrawal at the beginning of life because their mothers had been using opioids while they were in utero. And as the prescribing went up, obviously there was an enormous increase in women of childbearing age who became hooked on opioids, and we saw the consequences with the rise in neonatal opioid withdrawal syndrome. So I mentioned a moment ago that the epidemic began in the year 1996. On this graph, you can see why I said that, because on this graph, you can actually see the exact year that the oxycodone consumption takes off in the United States. And you see that it's in the year 1996. And you could look at this graph and you might know that 1996 was the year that OxyContin hit the market. So you might look at this graph and say, well, what we're looking at here is just the impact of a new opioid on the market that's being aggressively prescribed. OxyContin, it packs a whopping dose of oxycodone. It's being promoted and prescribed aggressively. And so this is simply the impact of OxyContin. And you would be mostly correct if you said that. But what you have to understand is that in 1996, it wasn't just oxycodone that went up rapidly. In 1996, morphine went up, hydrocodone went up, hydromorphone went up. Every opioid that was on the market in 1996, 1996 is the inflection point. It's the year that opioid prescribing practices really take off in the United States, not just oxycodone. And before I leave this slide, I want you to just take note of the red line at the bottom of this graph. That red line represents oxycodone consumption per capita in Europe. The blue line representing oxycodone consumption in the United States. And what you could see is that the United States has been just off the chart higher in per capita opioid consumption or oxycodone consumption in particular than Europe. Europe, unfortunately, has started to catch up. In the past few years, in many European countries, opioid prescribing has risen rapidly, in part because of the same reasons that the prescribing took off in the United States. It's now taking off in Europe. And I'm going to tell you now a little bit more about why that prescribing took off. What happened in 1996 that caused the prescribing to really explode the way that it did? Beginning in 1996, Purdue launched a multifaceted campaign to make the medical community feel more comfortable with opioids as a class of drug. They were eager to see OxyContin prescribed for common conditions. And this was a time when many in the medical community understood that opioid prescribing should be limited to severe acute pain or pain at the end of life. And so, starting in 1996, they sponsored 20,000 educational programs with the message that millions of patients are suffering needlessly because of an overblown fear of addiction, that we shouldn't be worried about the physical dependence that sets in when patients start to take opioids because patients can easily come off. We started to hear that opioids are safe and effective for chronic pain. We started to hear that if your patient looks like they're getting addicted because they're coming in asking for higher and higher doses, that they don't have real addiction, they have something called pseudo addiction. All of these messages, of course, were totally false, but the medical community began hearing them from every direction. From every direction, we were hearing that if you're a compassionate clinician in the know, you'll understand that opioids are a gift from Mother Nature and should be used much more for just about every complaint of pain. And as the medical community responded to this campaign and the prescribing took off, it really did lead to the epidemic that we're dealing with today. Now, many could understandably ask, well, how could clinicians have been so gullible? What you have to understand is that these messages were not just coming to us from Purdue Pharma. We were hearing these messages from every direction. In these 20,000 educational programs, we were hearing them. We were hearing them from professional societies like the American Academy of Pain Medicine and the American Pain Society, which issued a consensus statement calling for much greater use of opioids and saying that the risks of opioids, including addiction and respiratory depression, had been overblown. We were hearing these messages from organizations that the pharmaceutical industry created, like the American Pain Foundation. These were organizations meant to look like grassroots organizations of pain patients, but these were not grassroots organizations. They were artificially created by the industry to look like grassroots organizations. These were astroturf organizations. And we began hearing these messages from the Joint Commission, which, as you know, accredits hospitals. And the Joint Commission began working closely with the opioid industry and with the pain organizations that the industry was funding to create new rules for hospitals. And it was in around 2000, 2001 that the Joint Commission rolled out the pain management standards, would bring us the smiley faces and the frowny faces that are ubiquitous in hospitals to this day. Now, if you think for a moment about the pain management standards, had the Joint Commission said to hospitals across the country and to healthcare systems that they accredit, we are going to mandate that you assess patients for pain if they have a developmental disability and they can't communicate, you should show them the frowny faces and the smiley faces to see whether or not they have pain. We don't know about it. If they had issued that mandate, it would have made sense. If they had said, if you've got a patient who has dementia and might not be able to communicate and could be in pain, show them the smiley faces and frowny faces, that too might have made sense. If they had said for patients who've just come out of surgery and we should assess them to see if they have any pain, that also would have made sense. But that isn't what the Joint Commission did. What the Joint Commission did was to require all patients who were treated by a healthcare organization that they were auditing, all patients needed to be assessed for pain. The way it worked at one of the hospitals that I worked at, uh, even if you came into the mental health clinic and wanted to sit down with a social worker because you were depressed or anxious, the requirement was that you be assessed for pain. We actually had to show you the smiley faces and frowny faces before you could sit down with a mental health professional. And if you circled the frowny face indicating physical pain, the hospital policy said refer to pain management. And when that patient got to pain management, you can take a pretty good guess at what they would have been prescribed. And it wasn't just the Joint Commission that set new rules for hospitals, but CMS, the federal government, CMS is the federal agency that monitors Medicare and Medicaid. The CMS also began to require or financially incentivize aggressive opioid prescribing. Many of you who work in hospitals may be familiar with HCAHPS and the survey that patients receive after they've left a hospital. It's a survey that's intended to measure quality of care, and quality of care is something that CMS uses to determine how much hospitals get paid. And unfortunately, shortly after the Joint Commission came up with the pain management standards, CMS jumped onto this and decided to include in the survey for patients leaving hospitals questions about whether or not they received opioids every time they could have needed the opioids. And so the survey included a question that asked a patient, did you feel you needed pain medicine while you were in the hospital? And if the patient said yes to that question, there were two follow-up questions along the lines of, did you get that pain medicine every time you wanted it and quickly enough? And if patients left hospitals and indicated on the survey that they didn't get a pain medicine when they wanted it, the hospitals would be financially penalized. This also led to much more aggressive use of opioids in hospitals. And so many hospitals began encouraging more aggressive use of opioids so that they wouldn't be financially penalized by CMS if patients gave negative answers on the pain management survey questions. Fortunately, though, CMS did remove the pain management questions, so there really is no longer a financial incentive or financial pressure on medical centers to prescribe opioids aggressively. Unfortunately, though, that many who work in hospitals never got that memo. So there is still a perception among many hospital staff that they're expected to prescribe opioids aggressively or that the hospital could be dinged financially or by the Joint Commission. Let's talk a little bit about opioid prescribing trends. So beginning around 2013, prescribing in the United States began to trend in a more cautious direction. As you can see on this graph, uh, during 2016 to 2022, the rate and size of opioid prescriptions from surgeons in the United States declined. Unfortunately, though, as when COVID hit, we really began to see a plateauing. And so opioid prescribing has stopped coming down at the same rate. We're sort of now we've plateaued at a level that's still much higher per capita than other countries in the world with good healthcare systems. So the prescribing did trend in a more cautious direction, but we do have a ways to go before we get to more cautious use. How does the United States compare to other countries in opioid prescribing? So, a study that was done a few years back now, the United States was compared to several other countries by focusing on some specific surgical procedures that generally don't require a large amount of opioids when patients are discharged. They looked at cholecystectomy, appendectomy, and hernia repair and compared opioid use for those three surgical procedures in the United States to these other countries. And what you could see when you look at all of these other countries, you can see the median and mean number of pills that patients were sent home with from the hospital. You can see that in the United States, the median number of pills was 20, whereas in all of these other countries, the median number of pills was 0 because it is not routine to send patients home with opioids after minor surgical procedures. So again, the United States continues to be an outlier in the world in our opioid prescribing practices for acute pain. Why should we care so much about opioid prescribing for acute pain? Well, we know that an aggressive opioid prescription can lead to a patient winding up stuck on opioids. In this study that was published by the CDC, you can look at the likelihood of a patient winding up on long-term opioids based on the characteristics of their initial prescription. And you could see that if a patient was prescribed an opioid for 10 days, 1 in 5 patients remained on an opioid a year later. If a patient was prescribed 30 days of opioids, nearly 40% of patients were still taking opioids 1 year later. So an aggressive opioid prescription dramatically increases the likelihood of a patient getting stuck on opioids. If we think about many hospital pain management policies that developed as a consequence of the Joint Commission pain management standards, Pain management policies to this day in hospitals across the country are generally driven by two incorrect assumptions. One incorrect assumption is that you can ask a patient to rate their pain from 1 to 10 and then treat that number as if it's an objective measure. That's obviously not true. What one person indicates is a 10 in pain from 1 to 10, another person could potentially describe as a 2. A patient's reported pain score is not objective, it's a subjective measure. Another incorrect assumption around hospital pain management policies is that opioids are our best, strongest pain medicines. That yes, they have these risks of addiction, there's a risk of overdose if someone takes too much, but these are the big guns. If someone's got really bad pain, you want to give them an opioid because those are the best pain medicines we have. That's actually not true. If you look at the data on treatment of acute pain, opioids are often not necessary. NSAIDs can be just as effective for severe acute pain as opioids, and in some cases, more effective. In this study, opioids were compared to NSAIDs for the treatment of fractures, which are obviously very painful, and they found that the non-opioids were just as effective as the opioids with less adverse effects for fractures treated in emergency rooms. In this systematic review for musculoskeletal pain, you can see that opioids were often unnecessary. In this systematic review of opioids for acute musculoskeletal pain, they found that oral opioids provide small or no benefit above placebo, that intravenous morphine was helpful for sciatica, but oral opioids, the benefit was small to none when it came to treatment of musculoskeletal pain. How about opioids for renal colic, kidney stone pain? In this study, we see that opioids did not perform better than NSAIDs for the treatment of renal colic, which, as we all know, is excruciating. What about molar extractions, wisdom teeth extractions? To this day, adolescents are routinely prescribed opioids after their wisdom teeth come out. In this study, a combination of ibuprofen and acetaminophen performed better than opioids. And yet opioids continue to be prescribed, unfortunately, for adolescents. So let's talk now about bringing the opioid crisis under control. There are three general strategies that are necessary. One is what we would term primary prevention, which is preventing people from getting addicted to opioids in the first place. And then there's secondary prevention, which is trying to link patients with opioid addiction to treatment as quickly as you can before their opioid addiction becomes severe, before they begin to suffer adverse consequences from their opioid addiction. And then lastly, we need to treat people who have opioid use disorder so they don't die from the disease and so that they can function and participate in their communities and take care of their families. When it comes to preventing opioid use disorder, much of that really does rely on the medical community to prescribe more cautiously. To this day, people who are developing opioid use disorder often develop the condition from a prescription that came from a well-meaning clinician, a prescription that may have gotten a patient who took the prescription hooked, or a prescription that was more pills than needed, wound up in a medicine chest, and ultimately led to somebody becoming addicted. When it comes to identifying opioid use disorder, and treating opioid use disorder, that too does often fall on us as medical providers, including people working in acute care settings. Very often, patients with opioid use disorder wind up in an emergency room, sometimes being treated for an opioid overdose. Increasingly, hospitals across the country are initiating treatment for opioid use disorder, for example, with buprenorphine in these settings. That type of response will save lives and may be one of the reasons why we're seeing overdose deaths come down nationally. I'd like to end now on a somewhat positive note. Something we know is that as prescribing began to trend in a more cautious direction beginning in around 2013, nationally we didn't see overdose deaths coming down. The decrease in prescribing was happening at a time when the black market supply was becoming much more dangerous because of fentanyl. And so the benefit that we might have seen with more cautious prescribing was overshadowed by this much more dangerous supply. But someplace where we have been able to see a benefit, a very real benefit, from the more cautious use of opioids in the United States has been neonatal opioid withdrawal syndrome. And what you see here is data from just a few states. The data from states across the country looks like this. You can see that as prescribing was going up, the number of infants born opioid dependent in the United States was rising rapidly. And shortly after prescribing began to move in a more cautious direction, we began seeing significantly fewer infants born opioid dependent, infants needing to be treated for opioid withdrawal at the beginning of life. And so, what this tells us is that as prescribing trends in a more cautious direction, fewer Americans are becoming opioid addicted. This shows us that as prescribing trended in a more cautious direction, there was a significant decrease in women of childbearing age getting hooked on opioids. So this really does give us reason to be hopeful, reason to know that if we continue to improve our prescribing practices, we can ultimately bring this crisis under control. Thank you.